Hello friends. Now today we are going to talk about chapter 4 of Robbins, hemodynamic disorder, thromboembolic disease and shock. It is very important chapter. So let's begin. And during this video we will be talking mainly about edema. So let's discuss introduction first of all. The health of the cells and tissues depend on circulation of blood, which delivers oxygen and nutrients and removes wastes generated by cellular metabolism. That is very basic thing. Under normal condition, as blood passes through capillary beds, proteins in the plasma are retained within the vasculature, and there is little net movement of water and electrolyte into the tissue. This balance is often disturbed by pathologic conditions that alter endothelial function, increase vascular hydrostatic pressure, or decrease plasma protein content, all of which promote edema, the accumulation of fluid in tissue resulting from a net movement of water into extravascular spaces. Depending on its severity and location, edema may have minimal or profound effects. In lower extremities, it may only make one's shoes feel snugger after a long sedentary day. In the lungs, however, edema fluid can fill alveoli, causing life-threatening hypoxia. In structural integrity of blood vessel is the structural integrity of blood vessel is frequently compromised by trauma. Hemostasis is the process of blood clotting that prevents excessive bleeding after blood vessel damage. Inadequate hemostasis may result in hemorrhage, which can compromise regional tissue perfusion, and if massive and rapid, may lead to hypotension, shock, and death. Conversely, inappropriate clotting, thrombosis, or migration of clot embolism can obstruct blood vessel, potentially causing ischemic cell death or infarction. Indeed, thromboembolism lies at the heart of three major causes of morbidity and death in high-income countries: myocardial infarction, pulmonary embolism, and cerebrovascular accident, stroke. Herein, we focus on disorder of hemodynamics, edema, effusion, congestion, and shock, provide an overview of disorder of abnormal bleeding and clotting, thrombosis, and discuss the various forms of embolism. Okay, we will mainly discuss about edema and effusion in this video. Disorders that perturb cardiovascular, renal, or hepatic function are often marked by accumulation of fluid in tissues. Edema. So, what is edema? Accumulation of fluid in tissues or body cavities. Effusion. Effusion means accumulation of fluid in body cavities. Under normal circumstances, the tendency of vascular hydrostatic pressure to push water and salts out of capillaries into interstitial space is nearly balanced by tendency of plasma colloid osmotic pressure to pull water and salt back into vessel. So vascular hydrostatic pressure tends to push water and salt out of capillaries in and plasma colloid osmotic pressure tend to pull water and salt back into vessel. This is normal physiology. There is usually a small net movement of fluid into the interstitium, but this drains into lymphatic vessel and ultimately returns to bloodstream via the thoracic duct, keeping the tissue dry. Elevated hydrostatic pressure or diminished colloid osmotic pressure disrupt this balance and result in increased movement of fluid out of the vessel. If the net rate of fluid movement exceeds the rate of lymphatic drainage, fluid accumulates within tissue. The result is edema, and if a serosal surface is involved, fluid may accumulate within the adjacent body cavity as an effusion. See here, picture. Factor in influencing fluid movement across capillary wall. Normally, hydrostatic and osmotic pressure are nearly balanced so that there is little net movement of fluid out of vessel. Many different pathologic disorders are associated with increase in capillary hydrostatic pressure or decrease in plasma osmotic pressure that lead to the extravasation of fluid into tissue. Lymphatic vessel remove much of the excess fluid, but if the capacity for lymphatic drainage is exceeded, tissue edema result. You can see here, hydrostatic pressure tend to move water out of the capillary, plasma colloid osmotic pressure pulls, You can see here lymphatic tend to lymphatic duct to thoracic duct and eventually to left subclavian vein. This is all about physiology, revised physiology again. Edema fluid and effusion may be inflammatory or non-inflammatory. Inflammation-related edema and effusion are discussed in detail in chapter 3, in inflammation chapter. These protein-rich exudate means protein-rich fluid, accumulate due to increase in vascular permeability caused by inflammatory mediator. In contrast to in a non-inflammatory edema and effusion are protein-poor fluid called transudate. Transudate means protein-poor fluid. Non-inflammatory edema and effusion are common in many disorders, including heart failure, liver failure, renal disease, and malnutrition. Now we will discuss the various causes of edema. First cause: increased hydrostatic pressure. Increases in hydrostatic pressure are mainly caused by disorders that impair venous return. If the impairment is mainly If the impairment is localized, example a deep venous thrombosis (DVT) in a lower extremity, then the resulting edema is confined to the affected part. Condition leading to systemic increase in venous pressure, example congestive heart failure, are understandably associated with more widespread edema. Reduced plasma osmotic pressure. Under normal circumstances, albumin accounts for almost half of the total plasma protein. It follows that condition leading to inadequate synthesis or increased loss of albumin from the circulation are common causes of reduced plasma oncotic pressure. Reduced albumin synthesis occurs mainly in severe liver disease, for example, in-stage cirrhosis and protein malnutrition. An important cause of albumin loss is nephrotic syndrome, in which albumin leaks into the urine through abnormally permeable glomerular capillaries. In nephrotic syndrome, albumin leaks into urine through abnormally permeable glomerular capillaries. Regardless of cause, reduced plasma osmotic pressure lead in stepwise fashion to edema, reduced intravascular volume, renal hypoperfusion, and secondary hyperaldosteronism. Not only does the ensuing salt and water retention by kidney due to hypoperfusion, the RAS system, renin-angiotensin-aldosterone system get activated, and we will discuss that. Not only does the ensuing salt and water in retention by kidney fail to correct the plasma volume deficit, but it also exacerbates the edema because the primary defect or low plasma protein level persists. So, what is to answer say that? So, salt and water retention by kidney will not correct the plasma volume deficit because primary defect, low plasma protein, still persists. Sodium and water retention. How sodium and water retention causes edema? Increased salt retention with obligate retention of associated water causes both increased hydrostatic pressure due to intravascular fluid volume expansion and diminished vascular colloid osmotic pressure due to dilution. Salt retention occurs whenever renal function is compromised, such as in primary kidney disorder and cardiovascular disorder that decrease renal perfusion. One of the most important causes of renal hypoperfusion is the congestive heart failure, which, like hypoproteinemia, result in the activation of renin-angiotensin-aldosterone axis. Renal hypoperfusion um, one of the most important causes of renal hypoperfusion is congestive heart failure, which, like hypoproteinemia, result in activation of RAS. In early heart failure, this response is beneficial as the retention of sodium and water and other adaptation, including increased vascular tone and elevated level of antidiuretic hormone, improve cardiac output and restore normal renal perfusion. However, as heart failure worsens and cardiac output diminishes, the retained fluid merely increases the hydrostatic pressure, leading to edema and effusion. Lymphatic obstruction, trauma, fibrosis, invasive tumor, and infectious agent can all disrupt lymphatic vessel and impair the clearance of interstitial fluid, resulting in lymphedema in affected part of the body. The dramatic example is seen in parasitic filariasis, in which organism induces obstructive fibrosis of lymphatic channel and lymph node. This may result in edema of the external genitalia and lower limb that is so massive as to on the appellation elephantiasis. Severe edema of the upper extremity may also complicate surgical removal and or irradiation of breast and associated axillary lymph node in the patient with breast cancer. So, surgical removal or irradiation of breast and associated axillary lymph node causes severe edema of upper limb. In filariasis or elephantiasis, it results in edema of lower limb and external genitalia. So, you can see pathophysiology categories of edema. Increased hydrostatic pressure is caused by impaired venous return mainly. Why impaired venous? How impaired venous return causes? Due to congestive heart failure, obstructive pericarditis, ascites, that is liver cirrhosis, venous obstruction or compression, thrombosis, external pressure, example mass. Venous obstruction or compression is caused by thrombosis or external pressure. Lower extremity inactivity with prolonged dependency. These all causes impaired venous return. And arterial dilation also causes increased hydrostatic pressure. How? By heat and neurohumoral dysregulation. Reduced plasma osmotic pressure, hypoproteinemia. How hypoproteinemia is causes? Due to protein lodging glomerulopathies, that means nephrotic syndrome, liver cirrhosis, in malnutrition, in protein logic gastroenteropathy. Now, third cause is lymphatic obstruction. How lymph is obstructed? Lymphatic is obstructed due to inflammatory reason, neoplastic, post-surgical, post-radiation. Now, again, next cause is sodium retention. How sodium retention causes? Why sodium retention causes? Due to excessive salt intake with renal insufficiency, increased tubular reabsorption of sodium. Why tubular reabsorption of sodium causes? Due to renal hypoperfusion, increased renin angiotensin aldosterone secretion. Inflammation also causes edema. How? Acute inflammation, in chronic inflammation, in angiogenesis. In all these situations, edema occurs. Mechanism of edema in heart failure, renal failure, and malnutrition, and hepatic failure, and nephrotic syndrome. What is the mechanism of edema? In heart failure, there will be increased hydrostatic pressure, which lead to edema. There will be decrease in renal blood flow, which leads to activation of renin-angiotensin system, which causes retention of salt and water, which increases blood volume and causes edema. In malnutrition, decreased hepatic synthesis in nephrotic syndrome. In all this situation, there will be decreased plasma albumin. Decreased plasma albumin causes decrease in plasma osmotic pressure. Decrease in plasma osmotic pressure causes edema. In renal failure also, renal failure causes retention of sodium and water, which increase blood volume and causes edema. This is all our pathophysiology of edema. Now let's move to morphology of edema. Edema is easily recognized grossly, microscopically. It is appreciated as clearing and separation of the extracellular matrix, ECM, and subtle cell swelling. Edema is most commonly seen in subcutaneous tissue, the lungs, and the brain. In these three areas, the edema is most commonly seen. In subcutaneous tissue, edema. Subcutaneous edema can be diffuse or more conspicuous in the region with high hydrostatic pressure. Its distribution is often influenced by gravity. Example, it appears in the leg with when standing and sacrum when recumbent. What do you mean by recumbent? Remember from anatomy. A feature termed dependent edema a feature term dependent. That these are dependent edema that depends on gravity. Finger pressure over a markedly edematous subcutaneous tissue displaces the interstitial fluid and leaves a depression, a sign called pitting edema. We'll see picture about pitting edema later. Let's see picture. You can see a pitting edema. This is pitting edema. Mm. Edema resulting from renal dysfunction often appears initially in part of the body containing loose connective tissue such as eyelid. Periorbital edema is thus a characteristic finding in severe renal disease. Let's see picture of periorbital edema. You can see periorbital. This is periorbital edema. With pulmonary edema, lungs are often 2 to 3 times their normal weight, and sectioning yields frothy, blood-tingled fluid, a mixture of air, edema, and extravasated red cell. This is pulmonary edema. In brain, edema can be localized or generalized depending on nature and extent of pathologic process or injury. The swollen brain exhibit narrowed sulci and distended gyri, which are compressed by unyielding skull. We will discuss in chapter 28. Effusion involving the pleural cavity, hydrothorax, the pericardial cavity, hydropericardium, or the peritoneal cavity, hydroperitoneum, or ascites, are common in wide range of clinical setting. Transudative effusion are typically protein poor, translucent, and straw colored. An exception can are peritoneal effusion caused by lymphatic blockage, chylous effusion, which may be milky due to presence of lipid absorbed from the gut. In contrast, exudative effusion are protein rich and often cloudy due to the presence of white cell. Exudative effusion. Exudative effusion are protein rich and often cloudy due to presence of white blood cell. In chylous effusion, it is milky in color due to presence of lipid absorbed from gut. Let's see picture of hydrothorax, hydropericardium, and pericardium and hydroperitoneum. This is hydrothorax, accumulation of fluid in pleura. You can see a radiograph. Fluid is accumulated in pleura. Hydropericardium, fluid is accumulated in pericardium. Here, you can see here abdomen is distended. Due to this is hydroperitoneum. Fluid is accumulated in peritoneum. Now let's move to clinical feature of edema. The consequences of edema range from merely annoying to rapidly fatal. Subcutaneous edema is most important primarily because it signals potential underlying cardiac or renal disease. However, when significant, it can also impair wound healing and clearance of infection. Pulmonary edema is a common clinical problem that is most frequently seen in setting of left ventricular failure. It can also occur with renal failure, acute respiratory distress syndrome, and pulmonary inflammation or infection. Edema is pulmonary edema in pulmonary interstitium and alveolar space impairs gas exchange, leading to hypoxemia, and also create a favorable environment for bacterial infection. Pulmonary edema is often exacerbated by pleural effusion, which may further compromise gas exchange by compressing underlying pulmonary parenchyma. Peritoneal effusion, ascites resulting most commonly from portal hypertension, are prone to seeding by bacteria, leading to serious and sometimes fatal infection. Brain edema is life-threatening if severe brain substance can herniate, extrude through the foramen magnum, or the brainstem's vascular supply can be compressed. Either condition can injure the medullary center and cause death. So, summary of the key concept we have learned up to now. Edema is the result of movement of fluid from the vasculature into interstitial space. The fluid may be protein poor, transited, or protein rich. Exudate. Edema may be caused by increase in hydrostatic pressure, example heart failure, decreased colloid or osmotic pressure caused by reduced plasma albumin either due to decreased synthesis, example liver disease, protein malnutrition, or to increased loss, nephrotic syndrome, increased vascular permeability, example inflammation, lymphatic obstruction, example infection or neoplasia, sodium and water retention, example in renal failure. So this is all about edema. So we will discuss about hyperemia and congestion in our next video. Thank you.